Dr. Lin, we're here at Glaucoma 360 today, and you gave a presentation earlier on refractive considerations in cataract surgery in glaucoma patients. Could you elaborate more on your presentation?
Well, what's really important is that we all, general ophthalmologists, glaucoma specialists, we all do cataract surgery, and in those patients who have glaucoma, or even glaucoma suspects, we have to be very cognizant as we're selecting the intraocular lens, particularly these, what we call premium IOLs. That includes torics, multifocal IOLs, or combination of the two.
You also spoke about limbal relaxing incisions in relation to that. Could you talk more about that?
Correct. So that is still an option. I think most of us have done these limbal relaxing incisions. They're very easy to do. Just takes a minute. However, there is a limitation how much correction of astigmatism you can get. It's only in the range of up to 0.75 diopters to 1.25 diopters, depending on with or against the rule of astigmatism.
Okay, and what about intraoperative perimetry? You also mentioned that briefly in your talk.
Right. In the past few years, this technology has become available from at least 2 companies, and it really allows the surgeon to, number one, double check if the power is correct for the intraocular lens that's been predicted by preoperative measurements. It also allows you to orient or reorient your intraocular lens that's a toric intraocular lens. And in particular, it's been particularly helpful perhaps for patients who've had refractive surgery, such as LASIK surgery, as well as patients who are going to get a toric lens, and where you can really fine-tune where that placement of the lens is.
So what's the take-home message for the clinician?
The take-home message is really when you are considering cataract surgery in the glaucoma patient, you have to take extra time, both yourself in determining whether this patient is appropriate for an intraocular lens that's a premium lens, such as a toric or multifocal, or both combined. And you also have to make sure that you talk with the patient a lot. Their expectations have to be correct, because if they have some visual field loss, for example, they may still want a premium lens, but they have to understand that there's going to be some limitations and perhaps even some issues down the road. And we didn't mention pseudoexfoliation, for example, which is very common here in San Francisco and elsewhere. You may not even want to put a premium lens in because there's a chance for late dislocation or just some zonular dialysis associated with it.